Hello, my name is Georgette Delgado and today I'm gonna talk about prevention of early ventilator-associated pneumonia after cardiac arrest. Let's start with the definition. What is pneumonia? Pneumonia is an infection that inflames the air sacs in one or both lungs. The air sacs may fill with fluid or pus, causing cough with phlegm or pus, fever, chills, and difficulty breathing. A variety of organisms, including bacteria, viruses, and fungi, can cause pneumonia. VAP. What is VAP? Ventilator-associated pneumonia is a pneumonia that develops 48 hours or longer after mechanical ventilation is given by means of an endotracheal tube or tracheostomy. Ventilator-associated pneumonia results from the invasion of the lower respiratory tract and lung parenchyma by microorganisms. Key facts. Mayo Clinic minor, is pneumonia bacterial or viral?
When you have a respiratory illness, you might think,
Well, I've got a bad cold, I'll get over it.
but Dr. Vandana Bide says sometimes you don't get better.
If somebody's coughing up a lot of stuff, it may just be the tail end of a cold, but if it doesn't go away, it may be a pneumonia.
Pneumonia, a lung infection, comes in two forms: bacterial, which can often be treated with antibiotics, and viral, which can't. It's tough to tell the difference. Both can cause symptoms that include fever, cough, shortness of breath, and both make you feel run down. The strain called walking pneumonia causes similar symptoms, but you're still able to push through the day.
That's caused by a very specific bacteria. It is treatable.
Doctors diagnose pneumonia by lab tests and chest x-rays. The pneumonia vaccine helps protect you against certain strains. For the Mayo Clinic News Network, I'm Vivian Williams.
Applications in medicine. Ventilator-associated pneumonia. VAP is defined as pneumonia in a mechanical ventilated patient that is not clinically present at the time of intubation. The time frame for development of VAP is typically 48 hours or more after intubation, as this is when the disease typically manifests itself clinically. VAP has been implicated as the most common infection complication occurring in the ICU patients and results in prolonged ICU and hospital lengths of stay, prolonged duration of mechanical ventilation, and overall increased cost of care. To understand better, ventilator-associated pneumonia prevention.
There are better ways to make your mark here at Kaiser Permanente. Please sanitize or wash your hands at every stop. Our patients are counting on you to keep it clean. Every patient, every time.
Good morning. Who do we have here?
This is Laura Ketterman, 35. She was admitted to the medical surgical unit a week ago with the flu. She did not receive the flu vaccine. 3 days ago, she was transferred here and intubated. Yesterday, she became febrile, and chest x-ray indicates right lower lobe pneumonia. The culture's pending and PCR indicates it's probably Staph aureus. We're concerned that it's MRSA.
So our patient developed this infection in our ICU after she was admitted and intubated?
Definitely, this developed post-intubation, which makes it absolutely a hospital-acquired pneumonia.
Does anybody have any idea how this happened?
What about poor hand hygiene? Staph aureus, including MRSA, is most commonly transmitted by contaminated hands.
I agree, hand hygiene is the best place to start. Or it could have been an omission of any of the things that we do every day in the ICU to prevent ventilator-associated pneumonia. We could have missed oral care with chlorhexidine. We could have missed elevating the head of the bed from 30 to 45 degrees. We could have missed the daily sedation vacation or an assessment of the readiness to extubate. So what do we need to do to make sure that we do these things with every ventilated patient in the ICU every day?
So please let's review the therapies.
Wash or degerm your hands for every patient, every time.
Pros and cons. Risk. Given an increased risk for ventilator-associated pneumonia among patients who are treated with targeted temperature management after of hospital cardiac arrest with shock-able breathing, research examined how preventive short-term antibiotic therapy influences this risk. Prevention. In this multi-center, double-blind, randomized, placebo-controlled trial, 198 adult patients older than 18 years old in intensive care units were randomized to receive either intravenous amoxicillin clavunated, a dose of 1 gram and 200 milligrams respectively, or placebo 3 times a day for 2 days starting less than 6 hours after the cardiac arrest. Analysis. Results. The analysis was performed on 194 patients. Of these, 60 cases were identified to have ventilator-associated pneumonia, including 51 of early ventilator-associated pneumonia. They observed a lower incidence of early ventilator-associated pneumonia in patients receiving 32 to 34 degrees targeted temperature management strategy after out-of-hospital cardiac arrest with initial shock-able breathing in correlation to receive of a 2 course of antibiotic therapy with amoxicillin clavunated versus placebo. No significant between group difference were evident in terms of ventilator-free days and mortality at day 28. Issue applied in Ecuador. BAP problems with cardiac arrest. From August 18, 2014 to September 14, 2017 in Ecuador, a total of 1,166 patients were screened in the emergency departments of the trial centers. The main reasons for screening failure were out-of-hospital cardiac arrest with non-shockable breathing in a hospital cardiac arrest in an interval of 6 hours or longer between to return of a spontaneous circulation and randomized aspiration pneumonia and moribund status. Cardiac arrest. What is a cardiac arrest?
Your heart has an electrical system that regulates your heartbeat and keeps blood pumping around your body. A cardiac arrest happens when a problem in this electrical system causes your heart to stop pumping blood. It's commonly caused by a heart attack or an inherited heart condition. Max wasn't aware that he had an inherited heart condition until he had a cardiac arrest while at work. The electrical circuit in Max's heart stopped working as it should. Instead of beating regularly and effectively pumping blood around his body, Max's heart quivered, stopping blood flow and causing him to collapse. This life-threatening heart rhythm is called ventricular fibrillation, or VF for short. Max will have no memory of collapsing, as the lack of blood and oxygen to his brain caused his brain cells to die, creating temporary memory loss. Max was unconscious, unresponsive, and not breathing properly. His colleague quickly called 999, and another began CPR. Chest compressions took over the role of the heart, which kept blood flowing around Max's body. Rescue breaths made sure oxygen continued to get into his blood through the lungs. Both were crucial for keeping Max's brain functioning. On the phone, the emergency operator instructed Max's colleague to find a defibrillator. They followed its instructions.
Press the pads firmly to the bare skin of the patient.
And delivered an electrical shock to try and restore Max's normal heart rhythm.
Shock advised.
However, Max didn't regain consciousness, so his colleague continued CPR. Paramedics soon arrived and transported Max to hospital for further treatment. Max had the best possible chance of recovery, thanks to immediate CPR that kept blood pumping to his brain and body. For more information on cardiac arrest, visit bhf.org.uk/cardiac arrest. BHF. Beat heartbreak from cardiac arrest. Beat heartbreak forever.
Conclusion. Many trials of prevention measures have reported decrease in VAP rates, but a few have shown an impact on patient length of stay or mortality. The following measures decrease patients' ventilator days and mortality: daily interruption of sedation and daily assignment of fitness to extubate, ventilator weaning protocols, and digestive decontamination with oral and parenteral antibiotics. Key points.
VAP, ventilator-associated pneumonia, is an infectious complications which occur when patients are exposed to mechanical ventilation. And it's one of the complications that we really want to prevent and look at during the course of mechanical ventilation.
It's one of the most common infections in the intensive care unit patients, and it is associated maybe with some increased mortality, but more importantly with a prolonged hospital stay and prolonged mechanical ventilation and prolonged cost of care to manage those patients. And so therefore a lot of effort should be done to try to decrease the ventilator-associated pneumonia to improve the outcome but also the cost of care of these patients. I think there's plenty of evidence to suggest that if we do certain things by the way we deliver the care to our patients, we can minimize the risk of VAP. It's just a matter of educating the staff about the importance of every single step and then monitor their compliance with applying those steps.
This topic concerns the intensivist which treat this patient, but also the infectiologist and also the whole hospital and the infection control of the hospital. Because this is a disease for which we give a lot of antibiotics and we absolutely need to control the amount of antibiotics given, the duration of antibiotic therapy to limit the emergence of resistance within the hospital. So it's not a face-to-face problem of the doctor with the patient, but a global problem of hospital in general.
Thank you.